So, good evening, everyone. At the outset, thank you very much for the API of this part of Kerala for inviting me to do this. It's such a short time, they invited me because I've been scheduled to do a keynote lecture tomorrow for your one of your health ministry program being organized, by your local physicians and as well as your health ministry. So I was overheard by people that since I'm coming here, so invited to give this talk. And when I looked at this IMA house, such a beautiful thing in Chennai itself, we never had one. In fact, I've been heavily involved in IMA, our infectious disease society. Currently, I'm the vice president of the AIDS and Emerging Infectious Disease Society of India. Our national body. We never had one. It's so nice, and congratulations for having this. And I think this is an iconic building. And in fact, I've been to Cochin many times. I never knew this. Otherwise, I would have volunteered to give lectures here, at least for younger doctors, especially about the case presentation, which we keep doing this and stimulate a lot of discussions. Right. Again, thank you very much for inviting me. So what I'm going to do is, since I'm the only speaker, I will not bore you. So might be 30, 35 minutes. Is what I'm going to do is a little update about something new had happened in the field of HIV treatment. Many of you might be treating this already. Hey, what is there? Now, there are several doctors are treating what is new. It's always worth to many of you, and most of you have been private practitioners. I'm sure there are patients will want to know something what is new, what has not been given in the government program, national program, which everybody does. Is something what we have in private practice in all the fields, in not only in HIV, in all the fields. So what I'm going to do is I'm going to summarize some of the new changes just happened, still not implemented yet in the national program, and also some of the newer aspects in treatment and as well as prevention, which has very recently been developed. Some of you would have read in newspapers and media, which I came and spoken in some of those recent forums. So all those I might be, talking to you, in person. I'm basically a clinical doctor, infectious disease doctor, and also a clinical trialist. So I conduct, clinical trials, randomized clinical trials, drug developmental studies, and many of those antiretroviral drugs. In fact, many of those ARVs which you have been prescribing, many of them have been conducted. These trials are in my department at Chennai, where we have very large number of patients. So when you do clinical trials, it's very important. You need needy patients to participate voluntarily, so which is something we are good in that, not only in HIV, but also for hepatitis B, hepatitis C. And during the COVID time, we did that landmark trial stating that remdesivir never work for people who are really sick. That largest trial was done in my department, Solidarity. So why I'm saying this is very important. We clinicians, we keep prescribing drugs come from pharma, but it's very important how we can also contribute, to the science in terms of newer therapies. Not everyone can do clinical trials, but on the other hand, many private doctors can contribute in a way that if you're seeing some unwanted adverse effects, document properly and report to them, particularly in an event like this, so that it will be taken up by other academia to develop newer therapies. So otherwise, we might be keep prescribing the same old drugs with multiple adverse effects and many times drug modifications. You'll see some of my trials which I'm going to show. We may not know what exact dose, to be, developed, when you develop a new molecule. We always fix, say, 40, 50 milligram, you pick up this dose and do. Unless you use it in patients on a large scale, in clinical trial, we will not be using a large number. We may be using like 300, 400. You use a large number, you'll know that what exact dosage all needed. So I keep saying this in many, many meetings, especially private doctors, because they can play a very critical role. Alert clinical trial like us, hey, this we have been prescribing last 3 years, but this is something is happening. Why not go back and re-research, whether dose modification or changing the molecules and structures and things and so on and so forth. So with this brief background, I'm going to talk to you today. So about the global epidemiology, I'm not going to bore you with any of the numbers. So this is something what's been released by our national program every year at the end of somewhere near December, where it's called the World AIDS Day and World AIDS Week, where they release a number by the United Nations, which is an estimate, not headcount number. Last year, 2024, they released a number. It is around 39 million people living with HIV globally. And if you see these numbers in India, we have got almost around 2.5 million, which I'm going to talk to you soon on that. And also, this United Nations also estimate how many new infections are being estimated every year. So in 2024 alone, 1.3 million new infections were diagnosed globally and estimated. So this is quite a large number. And if you see this, our region, Asia Pacific, you have quite a large number, 300,000. And out of those, in the Asia Pacific, significant number from India and Thailand. So this is because these are the countries where they contributed very large number of infections. And also, United Nations also analyzed and published, stating that 23% of all new infections which happened last year, 2024, globally is from our Asia Pacific, particularly from India. So that means you might be seeing patients knowingly or unknowingly. They might be coming to you for portal hypertension. Unless you do a HIV test, you may not know. They may come to you with a lot of other things. You may not know that. So knowingly, unknowingly, you'll see this. Coming to India, again, our national program is called NACO, National AIDS Control Organization. Similar like any other national TB program, diabetic program, we do have this. So they estimate, and it has been estimated around 2 to 2.5 million people are living with HIV in India. Out of those, 1.8 million already been diagnosed and linked to treatment, and still another 500,000. So they do not know their HIV status. So this is a very critical population where they do not know their HIV status, and also they are viremic and they might be transmitting infection to their partners. So this is where clinicians can play a significant role in finding these undiagnosed people and link them to the treatment. Again, majority of the transmission happening in India, which you all know, in north, south, and west, is through sexual route. In eastern India, significant number of infections happens through injecting drug use, because that's a very common practice among young people. So HIV spreads, hepatitis C spreads, and hepatitis B. And in the prevalence, if someone asks you what is the prevalence of HIV in India, it's around 0.25. The numbers are very low as compared to diabetes and other things. But yeah, disease like HIV, 0.25 is quite a lot in terms of numbers, especially in a population like 1.2 billion. So if a small change in the decibel from 0.25 to 0.35, our number of HIV infected people will be huge. From 2.5 million, it may go to 3 million or 4 million. So that means that will impact on our healthcare system, especially on the medical doctors as well as the infrastructure we do have. Hence, keeping this prevalence under check is very important, especially in a country like India. Otherwise, our healthcare system will be burdened. And today, significant number of new infections are being getting diagnosed among young MSM, gay people, and as well as injecting drug users. When I say this, probably may think, hey, I'm not going to treat them, I may not handle them. It's not true. So there are people who might be married coming to you, they might have male partners. It's a very common practice now, even in the upper socioeconomic status there. Now, in my clinical practice, I see every other day one new infection, a young gay person who's also been married, mainly from the very high socioeconomic status. They're IT professionals or even pilots, or in variety of industry they have been involved. So this is something globalization had come into India. So these are all bisexuals where HIV is on the rise, as well as syphilis. Now, of course, injecting drug use is a very small close population. So the virus which is circulating is, we have two different viruses, HIV-1 and HIV-2. I will not talk more on that. The predominant one circulating in India is HIV-1. We do have various subtypes, A, B, C, D up to O. The one circulating in India is subtype C. It does not have major significance at this level for treatment, but when you have been talking about vaccines, one day it is developed, it will have significance on that. And good thing in India is all those people, almost everyone who have been diagnosed, are linked to antiretroviral treatment, either through the government program or through the private care. That's amazingly that happened in a country like India, where so diverse populations and culture, we are able to do this. And another good thing happened is the last 4 to 5 years, there's a huge decline in new HIV infections, that is HIV incidence, as well as there's a huge reductions in the death rate in HIV. So these are all attributed to the good care given by our doctors to our patients using these various medications, which I'm going to talk to you on this. So antiretroviral drugs prevents transmission, which you'll see some data which I'll show, as well as, of course, death. It goes without saying. And it's very importantly, as I said earlier, as clinicians, as internists, you can play a significant role to fill this gap, identifying the people who do not know their HIV status by offering HIV testing with their consent and link them to the treatment. So that means they will not be infectious to others, and we can even contain HIV the epidemic in India. Coming to the state of Kerala, which I did quickly today, So this is a number what's been reported by your Kerala Health Ministry. So I do not know the exact number. I mean tomorrow. I think tomorrow they are planning to release a new data. Here in Cochin. So it's almost around 29,000. It could be around 28 or around 30,000 people. Is what have been estimated. But for every people who are estimated, there might be 2 to 3 hidden infections might be there. So probably in Kerala state, probably you may have around 50 to 60,000. That's what I expect. But the government what reported is only 30,000. And also there are a lot of individuals from this state, Kerala. They come to us for treatment. In fact, in my clinic, I have at least, I can say, more than 1,000 patients even coming from the state of Kerala, for regular treatment. In fact, we tell them go to the doctors there. They don't want, take treatment either from Trivandrum or Cochin, Calicut. From throughout, people come. Nearly like 1,000 over a period of last 2 decades. Keep coming regularly and all doing, extremely well. And there is another number I put called 1,263, which I got it from your report from your national program. This is a new infections reported by your health ministry for last year. 2024, there are 1,263 new infections reported from the state of Kerala. And your prevalence in this state is very, very low, 0.07. I said for our national, it is 0.25. And for your state is 0.07. And also it is reported last year, the significant number of new infection happened among 19 to 25 years age group here in Kerala. So there's a spike in infections in this. Again, don't sit tightly with these numbers because you are surrounded by the heartthrob fire states. State of Tamil Nadu, we have a huge HIV population, but now it is contained. But still, we are third largest in terms of HIV infections. Of course, Karnataka, they have higher. Andhra Pradesh is today is the hottest place for HIV. So these are all your bordering states. A lot of trafficking happens across and migrations, and people go to work. So if you sit tightly, hey, I don't have infections here, you may see this because it's a migratory disease. So it's very important because bordered by states which have got a high prevalence. It's very important to know about this disease, how you can contain this, how you can manage this. Even if you don't manage, at least know about the disease and refer to the appropriate people. And going to the pathogenesis, before we talk about any treatment, you need to know about how this disease behaves, how it acts. Again, the pathogenesis, we keep adding newer things. Many of you would have seen similar slides, and also you would have read in your microbiology classes. But every 6 to 9 months, there are something new happening in terms of pathogenesis. HIV science is not like tuberculosis science, where we still have the same pathogenesis, what we learned. In fact, my father used to say, I prescribe the same medicine. They prescribe the same medicine what you still prescribing for TB, because there are not much thing happened at that time. But in HIV is very different because a lot of newer therapies coming up. That is all because of the newer science. So today, this virus, where you can see this is a cartoon of this HIV, which is an RNA virus, which is a retrovirus, RNA virus, which has got several coats, a carbohydrate coat, a protein coat, and an outer lipid coat. And also, like the COVID virus, this virus also has got several spike-like structures. We call it as glycoproteins. Some of the names are GP41, GP120, I'm sure you have heard in your microbiology classes, which are very important for the virulence and antigenicity of this virus. So this is a cartoon of our own T lymphocyte, and which contain our own genome, which is a DNA. As you all know that our T cell membrane is the one which anchors our T cell. And this T cell membrane on the surface also has got several surface receptors. One of the key receptor is called CD4, and also there are other chemokine receptors we call co-receptor like CCR5 and CXCR4. These receptors are very important physiologically for the function of our own cell. So for our cell to survive, to get oxygen, nutrients, these receptors are very, very important. So this virus, HIV, is a very brilliant virus. And today, if you look into all the microbes which we have studied, HIV is the most brilliant microorganism which we are not able to conquer it. But on the other hand, they taught us a lesson, continuously teaching us a various lesson in terms of pathogenesis, finding a drug, finding a vaccine, and so on and so forth. But all those efforts are not wasted. Whatever we are learning in this, we are now utilizing in other things. For example, develop the COVID vaccines, all the failures in this field, we used in that. And as well as some of the newer things. In fact, some of the therapies here, Nipah, the monoclonal antibodies, what's been developed, is all been initially developed for HIV, which, it did not work and subsequently repurposed for a lot of other viral diseases. Similarly, anything what we have been studying, Even it's not using here, it will be used for in other ways. So here, this is a very brilliant virus. This GP41 and GP120, these are the two glycoproteins which are present in the surface of this virus, which helps to identify the surface of the T cell membrane. And in the next step, what happens is GP41 helps to anchor this virus on the surface of the T cell membrane, and GP120, another glycoprotein in this HIV, helps to fix or fuse this virus on this CD4 or one of the chemokine receptor. So this is a very important and critical pathogenesis. Very, very important. Why I'm saying this is there are a lot of people talk about magical cure for HIV. Is it too loud? Too loud? Okay. So I can slow down. So there are people talk about magical cure. So especially from your state, a lot of Ayurvedic. We are not against any other system of medicine. People all talked about, especially in your state itself. We in fact went into a court case, even put somebody else out because they have been cheating patients and giving a lot of other alternate therapies. So without understanding a pathogenesis, we will not be able to find anything for this. It's very, very important. So the very important process in this virus is this. The virus never enters. It only identifies the surface of the T cell membrane, and the glycoproteins helps to fix this virus and helps to fuse. At the time of fusing, what happens is there is a process called uncoating happens. The carbohydrate, protein, and lipid code, which I said, uncoats, and because of this process, the RNA of this virus is introduced through these receptors into the T cell membrane. The virus never goes. Only the RNA, goes. If the virus goes, we can hit it. The RNA, only the genome goes, it can go and do variety of things. It can mutate and it can cause a lot of other things. If it is a virus, we can track it. What are the things going and, full viral bodies, we can get it. But only the RNA, it's very difficult to find a cure at this time. So all retroviruses, not only HIV, all retroviruses carries an enzyme called, reverse transcriptase. So this RNA of this HIV also carries this enzyme, which goes along with this virus, the RNA, which helps to change this viral RNA into a proviral DNA inside the T lymphocyte, and with the help of another enzyme called integrase, gets incorporated into the human DNA. It's a very important enzymatic pathway, and because of this, today we are not able to find a cure. Now, if we find something, it will also kill our own T lymphocyte. Then it becomes part of the human cell and multiplies into a lot of DNA particles. These are all integrated into the human DNA. Then translates and transcribes into millions of RNA particles, and with the help of an enzyme called protease, it maturates into millions of HIV virions. All happens inside the T lymphocyte and butts out, disrupting the T cell membrane, and the cycle repeats. So it's a very brilliant virus. Enters, the virus never enter, RNA is introduced, it uses all these enzymatic pathways, uses our own genetic code of DNA, and uses all those molecular pathways, translates, and maturates into millions of virus and causes the major destruction. So as you all know that when the T cell membrane is disrupted, the T cell dies off. All individuals pick up anything around them. It can be in infections, it can be because of the low immunity, it can be malignancies, it can cause a lot of inflammations. You name any disease, people with HIV can develop. And also today, based on the science and because of this pathogenesis, people with HIV can also develop various non-communicable diseases. People who are pre-diabetic can become diabetic. People who have got a risk to develop cardiovascular disease, they can develop, stroke or MI, because of this pathogenesis. So this virus, using this enzymatic pathway, replicates. So if you want to find anything to cure or to disrupt, you have to follow this pathway. Our major therapies, anything way back in the year 88, 89, were all targeted towards this whole genome. And what they found is they also killed our own T cell. It all became cytotoxic, like the cancer chemotherapy, which has got a more harm, to the individuals. And today that cannot be done. You need to use what is called selectively uses, like our Operation Sindhu, where you need to find selectively where this genome is all moving up, how these enzymes can be inhibited, or selectively how this genome can be replaced by using other things. So current generation of all the research is happening on how to get this out using this pathogenesis. Today, whatever I'm talking, in 6 to 9 months, I may add a little more. Now, again, if you call me after a year, I may add a little more, into this pathogenesis. Something what a lot of new things happening with this viral disease. Now, this HIV disease, another typical infectious disease like typhoid or tuberculosis or anything. You all know that all these infectious diseases have a typical natural history. Someone who develop an typhoid, they're not going to develop a full-blown symptom next day or the following day. It has got a small natural history, similar like a hepatitis B. So here in HIV, someone who is infected today, in 2 weeks to 3 months time, they'll have what is called abrupt increase in the viral replication, as shown by this pink color curve. So at this time, there will be a small drop in the T cells, which can be measured by a technique called FACS count, flow cytometry. It's an equipment we use it, where you can count the CD4 cells, and based on you can estimate what proportion are being these T cells using this CD4 receptor. So normally for an individual, the CD4 should be more than 350 or should be more than 500. So when there is an abrupt increase in the virus replication, anytime after 2 to 3 weeks, the CD4 cells will start dropping down. At this time, these infected individuals, they develop an illness which will be like similar like any other viral infection. We call it as acute infection or seroconversion illness, similar like a body pain, sore throat, sometimes rash. Less than 50% of them experience, and even they experience, they don't go to a doctor. They self-medicate with a antipyretic or analgesic, and another 50% they don't experience, they go away. But it's a very important period. This is a critical period where a lot of transmission happens. People do not know their HIV status. They're highly viremic. They may not have symptoms, and they can easily transmit it to their sexual partners. So this is the most important period where a lot of sexual transmission of HIV happens. So after 2 to 3 weeks, what happens is, like any other infectious disease, our human system stimulates to these antigens, to these virus, antibodies, which are due to the host immune response. So these HIV antibodies are produced anytime after 2 weeks to 3 months time. So if you want to do HIV testing soon after the exposure, if you do any ELISA or any antibody testing, it will become false negative. But all you have to do a PCR and do a molecular test at this time. So anytime after 2 to 3 weeks, they'll start developing antibodies where you can diagnose them. So these antibodies, what will help is, it helps to keep the virus at a very lower level, is what is called host immune response, which happens to every infectious disease, every pathogens, where the virus goes down, which is a very important phase, and the virus goes to a very, very, very low level for larger amount of time. At this time, CD4 count improves, and this period we call it as asymptomatic period. They will not have any symptom, they'll be perfectly fine. Looking at someone, you can't say that unless you do a HIV antibody test, but they can transmit infection to others. So this period, asymptomatic, can vary from anything from 2 years to 20 years based on the studies done in Chennai, in African settings, as well as in the United States. It also varies from individual to individual. Some people, they develop symptoms very quickly. Some people up to 20 years, they'll be perfectly fine. So after these 2 to 20 years, the host immune response cannot keep this virus under a check. The virus will start replicating, and the immune system will start dropping down over a period of time. When the CD4 cells start dropping, they can develop anything around them. One of the most common earlier manifestation is herpes zoster. Any young people who develop a herpes zoster think that they can have HIV, offer counseling and send them for testing. It can happen even at a higher CD4 of 500 or 600. And tuberculosis is one of the most common opportunistic infection. Many of you know that. When the CD4 drops to less than 500, they can develop. And Viridia oropharyngeal candida, which we see in diabetics and young kids, and as well as in people who are getting chemotherapy. But if you see in people who do not have those disorders, if they have candida, think that they can have HIV, and also particularly if they have palatal candida, think that they can have HIV. It's a profound immunosuppression causing oropharyngeal candida. And when the CD4 drops to less than 200, they can develop a variety of pneumonias. The one common is called PCP. It's caused by an organism called Pneumocystis jirovecii, which again, if you see a chest X-ray or a CT chest, it look like a COVID findings, like a ground glass appearance. Many times, even the radiologists say that it's a ground glass appearance, suspect COVID, due to PCP, can be similar like this. And again, when the CD4 lasts to less than 100, they can develop a variety of neurological opportunistic infections, starting from tuberculous meningitis, cryptococcal meningitis, toxoplasmosis. And also there is a virus called cytomegalovirus, which can also cause blindness, and because of the very low CD4, and due to the immunosuppression. This period we call it as, whereas advanced HIV disease, someone who enters this phase, again, very difficult to manage them unless we aggressively treat this opportunistic and you lose them. So today we do have treatment and cure for all these opportunistic infections. We can cure TB, we can cure Candida, we can cure PCP, and variety of all those neurological infections. Even if we keep doing this, the virus will continuously replicate and keep damaging their immune system. They can pick up one by one. And also we do have certain prophylactic drugs to prevent TB, which you all know, that IPT. We do have prophylactic drugs like very simple drug called cotrimoxazole to prevent PCP. We also have prophylactic drugs of fluconazole to prevent variety of fungal infections. So all this we give in people with HIV, which I'm not going to talk much on that because I wanted to focus more on antiretroviral therapy. The virus continuously replicate, but we do have medications to contain the virus replications. So these are called antiretroviral drugs. These are all not curative drugs. If you look into that, this chart looks like a Italian restaurant menu, where variety of all these names. So if you want to be a good HIV doctor, you need to, go through all those. There are variety of drugs being developed, and some of them I put strike and some of them are being killed because they're all very old drugs. They have been removed out of our guidelines because of lack of efficacy or adverse effects. I'll walk you through how these drugs work and how we are going to give it to a patient and what are the new changes happened very recently. I'm going to the same scheme. I'm going to the same pathogenesis slide. We do have some drugs called fusion inhibitors, which can block this viral pathogenesis at this level when the virus enters. This is what is called T20. When the virus enters using GP120 and GP41 through the CD4 receptor, it can block the viral entry, whereby we can disrupt the life cycle. We do have drugs which inhibit this enzyme called reverse transcriptase, starting from sidovudine to nevirapine efavirenz, and the latest one called doravirine, very recently approved, which can disrupt the life cycle at the time of changing from viral RNA to proviral DNA. So this is a very important phase where we do have medications available. We do have some potent drugs which are called integrase inhibitors, dolutegravir, which many of you might be using in your patients, and also other integrase inhibitors like raltegravir and elbitagravir and bictegravir, all inhibit this enzyme integrase, thereby disrupt the life cycle of getting integrated into the human DNA. We do have drugs which inhibit the enzyme protease, which are called protease inhibitors, called adasanavir, lopinavir, and darunavir, and we can disrupt the life cycle at the time of maturations. We do have some drugs called CCR5 inhibitors, called Maraviroc, which can block the CCR5 receptor, thereby the viral entry can be prevented. We also have a repurposed drug, which is a monoclonal antibody called imalismab, which can block the CD4 receptor, thereby the viral entry can be prevented. And very recently, 8 months back, we have a new drug being approved for use, which is called lenacapavir, which is a capsid inhibitor, which also acts at the time of maturation of this virus. So we have these multiple drugs being available. Using this and using the pathogenesis, we can completely disrupt the life cycle of all these viral applications. And if we can do that, we'll be able to make sure that these infected individuals, they'll maintain their immune system and their CD4 cells won't drop down, they won't pick up any infections, and they can live like a normal, healthy people. We cannot cure this even with all these medications, but we'll make sure that it still will multiply in a very small numbers, but we can make sure that they'll be perfectly fine. So this is something what had happened in the last 2.5 decades in the field of HIV medicine. With all those discoveries in newer therapies, we are able to contain, which used to be a death sentence once upon a time when we started our practice 25 years back. When someone used to be HIV, we always used to counsel their relatives that your neurons are not going to live for next 2 years or 2 months. But today, we tell our patient, you live like a normal people, which you're going to see at the end on looking at some of the data. Now, you may ask a question, when you're going to give this drug, because it's a slow chronic disease, some people develop symptoms after 2 years, some people after 20 years. So when you're going to do these drugs, when we started our initial work, we used to give only when people start developing symptom, when the CD4 is less than 300 or 200, started giving this. At that time, we didn't have much data on that. There are 2 landmark clinical trials. I feel proud to say that I was involved in both a clinical trial as a principal investigator. It's a large global trial done by US NIH in many countries. One of the largest sites in the globe is Chennai site, our clinic. So the first trial is called HPT-052. So this trial we conducted in people who don't need antiretroviral drug. They had a higher CD4. They are a serodiscordant couple. One of their partner has been negative. They are HIV positive, the partner is negative. So we wanted to study in this population by giving this antiretroviral drug where they don't need it, and also to another group who don't need it, they are just treated only for opportunistic infection. And we followed them, giving them safe sex counseling, condoms and everything, whether they are transmitting infection to their partners. What we found in this particular trial is people who are treated early, soon after the diagnosis, they are not transmitting infection to their partners. But people who are deferred till their old guideline of 300 or 200 CD4, they are transmitting infection to their partners. So that means treating early prevents sexual transmission of HIV to their partners. So we didn't stop with that. Now we also wanted to prove whether it has got a good benefit to the individual. If you say that, hey, you take the drug, another one will be prevented. So people are not going to take the medications, right? They said, why should I do this for somebody's benefit? So we went and did this large trial called START study, a global study, 120 sites. Again, our Chennai site is one of the largest recruiter for the trial. For anyone soon after the diagnosis, even at 800, 900 CD4, no opportunistic infection, we randomized to two groups. One group immediately starting treatment, another one we waited up to the guidelines of 350. We found that starting treatment yearly prevented almost all opportunistic infection, TB, you name anything they treated. And also we found that those individuals, we also prevented cardiovascular disease and malignancies which developed in individuals when the CD4 started dropping. And following all this, both are published in New England Journal of Medicine, and they are voted as one of the best discoveries in medicine at that time by the Science magazine. And today, every guideline, soon after the diagnosis, the next day you have to start on treatment. Don't even wait, because it is individual benefit as well as public health benefit. Following those results, we sat at that time in the WHO office in Geneva. Immediately, we developed a guideline. Someone who is HIV positive, they're symptomatic, start diagnosing all those opportunistic infection, TB or Candida, put them on treatment. Within 7 days, start on treatment. Make sure that they are stabilizing on their OI treatment and put them on antiretroviral drugs, what is called rapid ART. Don't wait, immediately put on them. Someone who's totally asymptomatic, come to your clinic, you diagnose this morning, you counsel them, talk to them about the therapy. If they accept, you can start even on the same day. If you don't do that, what will happen is they'll have a loss to follow. They'll come back to your clinic, might be after 5 years or 7 years, to your ICU or to your ER, and may die because they may not taking anything precautions. They may be transmitting infection to their partners, and they'll be sick and they come to you. So very important to link them to the treatment very immediately so that enormous benefit will be there. So today, all these are all implemented even in India. So if in your private practice, anybody comes to you, make sure that they immediately get treatment. It's very important for them as well as for their partners. Next question is, out of this Italian restaurant menu, what I'm going to choose? There are so many drugs. It's not like a TB drugs where you have 4 or 5. And again, even in diabetics, so many things, very easy, simple to use all those diabetic gliptins and various group of drugs. But in HIV, all those are so confusion. We have different groups of drug. How we are going to do it? Again, to make it simplify, we did various clinical trials using this for public health. We simplified all those. Some of the things, a lot of things we used to use a drug called nevirapine and efavirenz, which I'm sure if you practice HIV medicine, you would have used. We used a lot, but today we don't use it anymore. I put it down because the resistance to these drugs are rising in the general population. So because of the transmitted resistance, and following this, we don't use it in our practice anymore. And also, there are a lot of drugs which are getting prescribed even till today, even in Cochin or here in Ernakulam in your hospitals, will be changed in the next couple of months, which we just released new guidelines by WHO last month. So these are those changes. I'll walk to that. So this might be entirely new. Many of you are practicing doctors, even in the government program, may not be aware of that. So we are going to educate them tomorrow. Tomorrow there's a big health ministry meeting. Every government ART doctor for entire state of Kerala will be in Cochin tomorrow, organized by the health ministry. So they have a large training program. So today, what the guideline, what you're using is a 1 by 2021. So anyone who's HIV positive, we put them on, we don't put on anybody on any single drug. So if you put on single therapy, it suppresses the virus, but over a period of time, it can develop a resistance. Even put 2 drugs, it deepens the virus for a little more longer time, again develop resistance. You need 3 different drugs, acts at a multiple level, whatever I said that. So what is called triple therapy. Similar like in TB where we use 4 drugs initially. So the one which is prescribed to recommended is a combination of tenofovir, lamivudine, and dolutegravir. We call TLD. It's the one widely being used. We picked up this combination based on different clinical trials. What could be the best one for all population? Just for one at a time, I cannot go into that. But this drug combination is one of the best one, and we launched this in the year 2018. And it can be given in TB patients along with rifampicin, which you know that rifampicin is a drug which can produce drug-drug interaction to your proton pump inhibitor, to many protease inhibitors, antifungal drugs, so on and so forth. We're including to many HIV drugs. So this particular antiretroviral drug like dolutegravir, tenofovir, lamivudine will also interact. And because of that, we have done some studies and shown that you have to double the dose of dolutegravir. Someone who is on rifampicin containing therapy, but it's still safe, and you can double the dose of dolutegravir, still works very well. And also this combination of TLD is safer in pregnancy. So it is completely can be given. Hence, it was been picked up now last 7-8 years. It has been expanded globally. And today we have almost around 35 million people globally on this particular combination. So what this drug over a period of time does is, that's what I mentioned at the beginning. As private clinicians, how you can contribute immensely is similar like this. When we prescribe this, over a period of time, what happened is they developed what is called renal dysfunction. This is one of our publication. Many years back, we alerted to the global guidelines that tenofovir on a long run can produce renal dysfunction. And soon it was supported, our paper was supported by other work from other Asian countries. And following this, WHO and other guideline makers immediately developed guidance. Anyone who's on tenofovir, you need to have a close creatinine monitoring. After 2 to 4 weeks after initiating treatment, start on that. Then 6 months and 12th month and annually, you have to keep doing this. Still, they can develop a renal toxicity over a period of time. You know that managing nephropathy following a drug complication is so expensive in our country. Sometimes they may need a renal transplant. So again, to combat this, today we have developed another molecule, not still available in the national program, which will be soon will be introduced, might be tomorrow after the training program to the doctors, is what is called TAF, tenofovir alafenamide. Today, the presenting drug what we give is called tenofovir. So this is a pro drug called TAF, along with lamivudine and dolutegravir, which is also safer in pregnancy as well as in TB patients. What is the advantage to that is, again, I'm going to this cartoon. Tenofovir as a drug, when someone swallows, it won't get absorbed, it get excreted. But tenofovir disoproxil, which is currently given in combination with the TLD with 300 milligram, it get absorbed, but the larger chunk of the drug get excreted to the renal tubular cell function and causing some toxicities in the form of nephropathy. So, but only a small proportion of the drug goes to the target site by inhibiting HIV. But if you give this newer drug, which is not launched in the national program, but already available in the private program, which is called TAF, tenofovir alafenamide, where larger chunk of the drug go to the target site, very a small proportion excreted in a way of renal tubular cell function. And this is the beauty of these drugs. And following this, now this drug is now picked up anyone who got a high risk to develop a renal toxicity, particularly diabetic patient or hypertensives or elderly or postmenopausal women, where again tenofovir is not recommended. And tenofovir also can produce what is called BMD, bone mineral density loss, and because of they can develop a fractures where TAF will have a minimal one. So this is something, a new guideline change, which again you can look for. And again, if your patients who is on TLD on a long run, where you don't need to wait for them to develop a renal toxicity or bone toxicity, you can change them to this TAF containing therapy. Available as a fixed dose combination of TAF, emtricitabine and dolutegravir as a single pill. And also, the new guideline, which will be launched soon, also will tell someone who is already on antiretroviral drug with TLD, if they are virologically suppressed, you can even drop one of the drug, tenofovir, which has been more toxic, and continue with these two drug regimen, 3TC and lamivudine and dolutegravir, which is also available as a FTC, especially in suppressed patients, so that you can prevent the toxicities. Today, we do have antiretroviral drug where people live like a normal people, but on the other hand, the very important role of a treating doctor is like a football coach. Make sure that these drugs also don't harm the individual. It's very, very important. In a football coach, what it does is, there might be a player who might be doing very well, but he might be doing more foul. The coach will remove him out and put another player. Sometimes you may say, hey, doing well, but he want to protect him for the next match. I mean, get a red card. Similar like this, here you have to remove some of the drugs out and use appropriately. This is something what we learned in the last 2.5 decades, because people live longer with these medications, but it can produce the toxicities over a period of time. Again, these two drug therapies not recommended in hepatitis B co-infected people. As you all know that today the drug of choice for hepatitis B, even in a mono-infected, is tenofovir. That's a drug of choice, or TAF. And you can also given along with the lamivudine. We don't use entecavir, interferon or anymore. These are all little outdated, but still you can use it. But on the other hand, tenofovir drug of choice. Someone who is HIV positive and hepatitis B, you don't need a separate hepatitis B drug, because the drug of tenofovir and lamivudine takes care of that, as well as TAF also. But when you're giving this two drug therapy, you can't give that, because lamivudine will develop resistance to hepatitis B, as well as not recommended. This is something what the new guidelines will come, so especially to save somebody's kidneys. Someone, if you put on treatment, don't forget on that. You have to closely monitor them, because the whole objective of this antiretroviral drug is suppress the virus, make sure that the virus gets suppressed. The patients are not taking the drugs, the virus will go up and down, it gets blips, and they can develop a resistance. This is commonly which happens. Hence, you have to closely monitor these patients. You have to do what is called viral load monitoring. Soon after starting treatment, within 6 months, we do this, make sure they are virologically suppressed. And also, you have to do a CD4 monitoring, make sure that their immune system is intact If the CD4 is very low, you can give prophylactic drug to prevent opportunistic infections. And also, every visit you have to do a clinical monitoring. If you don't do all this viral load monitoring, you'll end up in seeing patients in your acute care facility with various clinical manifestation or with some toxicities. Again, there are modeling studies have shown the duration between virological failure and clinical failure is anything from 6 months to 2 years. So that means if you have not done a proper monitoring, you'll see them, clinically sick only after 2 years. By that time, a lot of destruction would have happened in their system. And following that, today we have a very strict virological failure definition. Someone who is virologically suppressed after 6 months, we repeat them every year annually. If they are viremic, again, you can improve the adherence, make sure that they take the medications and repeat the viral load within 3 months. And if they are not still virologically suppressed, you have to change from one line of therapy to another line of therapy. Otherwise, they'll develop a resistance. Today, some of the older drugs we used, a drug called nevirapine and efavirenz, have developed a lot of resistance when they failed. So these are some of the resistance mutation. I will not go into the detail for this crowd. The first resistant mutation occurs for a drug called lamivudine or emtricitabine, a mutation called M184V, and followed by the mutations for NNRT called nevirapine or efavirenz. This is something what happened very quickly. Hence, because of the reason, we removed that out of the guideline. Tenofovir is a drug very difficult to develop a resistance mutation. It's a potent drug. But on the other hand, the current drugs, what we are prescribing, that is a tenofovir, lamivudine, and dolutegravir, and several clinical trials have been done. Even if it failed, this meta-analysis shows very rarely they develop a mutation. So that means the current drugs, what we are using is such a potent drug, and if they take it very well, they live like a normal people. But again, we can't sit tightly with any such drug in an infectious disease. It can develop a resistance. And very recently, WHO also released a data stating that people who are not taking the drugs properly or their drugs are not prescribed properly, even dolutegravir, such a potent drug, can develop a resistance, and it's very important to improve the adherence in people. Then what is this resistance? You may all talk about this. So it can develop under suboptimal drug pressure. Somebody who's not taking the drug at all, they will never develop it. Only if they take today, tomorrow they are not taking, and after a couple of days they are taking. If they keep on periodically taking, can develop a resistance. And it can develop to all the genes, both reverse transcriptase, protease, and integrase. And once they develop, it's very important for the internists, they are permanently archived. Now, for example, if ciprofloxacin is negative for a urinary tract E. coli, in the next visit, it can be sensitive, you may still give that. But in HIV, once they developed, and even in the next testing, it shows no mutations, you can't use it. It will be archived, it will come back. They'll have a memory genes, will bring it back the minute when you expose. And some of the drugs were low genetic barrier. So that means even if they miss 1 or 2 doses, they can develop a resistance. Hence, for the reason, today we do trials and research on high genetic barrier drugs so that it can be pushed for a longer time. The drugs what we use like efavirenz and nevirapine are very low genetic barrier. If they miss few doses, they develop a resistance. Another one is called cross resistance. If they have been resistant to nevirapine earlier, it also resistance to efavirenz. And today we have a drug called dolutegravir. If they develop a resistance to that, there is another integrase available called bictegravir resistance. So that means you can't change from this drug to another. So this is something what need to know. There are a lot of clinicians make mistake. And also once they develop a resistance, if you don't quickly change this drug, it can keep accumulating and it can jeopardize future drugs which are under development. So this is something very bad happen to these patients if we are not acting properly. So there are a lot of new therapies under development, and because of the accumulation of resistance mutation that may not be able to use in future. Today, if someone fails the first line, we do have a second line. So the earlier therapy, what earlier we used called the TLE, tenofovir, lamivudine, and efavirenz, if they failed, we changed them to a drug called AZT3DC and dolutegravir. And again, AZT is a drug highly toxic. So we did some studies. I will not go into the details of this. With this, we showed that you don't need to change the therapy even if they fail tenofovir. We can even recycle them based on 2 different studies. A study called NODIA, as well as our own study in Chennai, as well as in Australia, we did called DEP study. What we did is, even if they failed tenofovir, we recycled them along with other potent drugs, and we found them it been worked very well and very effectively. And following this, very recently, last month, WHO changed the guidelines stating that even if they fail with tenofovir, I can change the third drug, efavirenz, to dolutegravir. You don't need to change them to tenofovir. If you fail them with the tenofovir and dolutegravir with the current drug, which is very rare, then you can change them the dolutegravir to a protease inhibitor called darunavir, but you can recycle this tenofovir. It's something, a new guideline change very recently had happened. So we do have a potent second line if they fail the first line. And also, we do have a third line if they fail the second line. And again, how you choose this third line is, well, you are doing clinical monitoring as well as virological monitoring. If they are viremic, and if they are continuously viremic even after adherence intervention, then you may have to do a resistant testing based on that. You can choose a drug, and one in the public health setting we propose is darunavir twice daily, and along with the dolutegravir, which will work on that. And today we do have a potent first line, potent second line, and a third line. There are studies have shown if the patients they take these medications regularly, anything from 7 to 10 years, they can keep on going on with the first line or even more, and another 7 to 10 or 15 years with the second line, might be another 15 years for third line. So if you add all those 10, 15 or anything, today for up to 25 to 30 or 40 years, we have potent antiretroviral therapy. Someone who is HIV positive, you start them on treatment at 25 or 30 years, for up to 70, 75 years, we have potent antiretroviral therapy. By the time they can be killed by other natural or unnatural disasters. So today, HIV is not anymore a death sentence. They live like a normal people. Harvard Medical School, their researchers, they did a modeling on looking into the quality of life of people with HIV, and they compared with their viremia, undetectable viral load, and good CD4. And they published a very nice paper in Lancet stating that couple of years back. So today, for people with HIV on antiretroviral therapy, they suppress viral load, good CD4, their life expectancy is similar to the people who don't have HIV. So that means people with HIV and don't have HIV perfectly fine. So you may ask a question. You want either a HIV or diabetes, you can ask for HIV. Because if you are diabetic, you can't eat this, do this, kidney can spoil, and so many other things are there. In HIV, my patient come to my clinic, they look like a normal people. I have people 30 years on treatment, perfectly fine. So they do all those and they have been perfectly fine. It's something what had happened, in the field of HIV medicine with all those research and newer therapies and so on and so forth. But very importantly, you want to achieve that, you have to suppress a virus, and that should be maintained. But the common response is, think you as a person, when you develop a sore throat, how many of you complete a course of an antibiotic, or any of your family members? All of us disrupt. When in HIV, all these powerful drugs, you ask them take every day lifelong, they tend to miss pills, and so this is the common response happens. Again, to combat this today, we are developing these molecules, these antiretroviral drugs, as a long-acting injections. Instead of taking every day, you can have a shot every 2 months, or every 4 months, or every 6 months. One such drug is developed is called dolutegravir, which I said earlier, in the form of cabotegravir, which is an analog of this drug, with a half-life up to 2 to 3 months, which has already been developed. There is another NNRTI called rilpivirine, which is a second generation NNRTI, which has also been developed for 2 to 3 months. There's a trial which happened called LATE-2, which validated these two particular injectable along with the everyday oral therapy, and they found that every 2 months, if you give these injections instead of taking every day or oral tablet in people who got virologically suppressed, it maintains suppression for next 2 to 3 years. And also, it was also been supported by two other trials called Atlas and Flare. Following this, US and UK and other European guidelines changed in a way that someone who is HIV positive on everyday oral therapy, if they got a suppressed viral load, you can change them to every 2 months of these injections. So that means you can get away from this adherence. But they have to come to the clinic to have a shot on this. Again, these two drugs are not very good drugs. They are very painful injections because it's not available in India, which we have. I've seen this in the US, where painful, but manufacturer working on a way that make me less painful. But on the other hand, we do have these drugs available, but they should be virus susceptible. You have to do a genotyping or not. That's the reason we didn't immediately implement in India and other countries. Very recently, there is a study being published from Sub-Saharan Africa. Even in people who got multiple resistance, even if you give these injections, I don't want to go into detail just for one at a time. They found that even with some mixture of resistance, this injectable worked very well. So following this, last month, we have updated our guideline in the World Health Organization, as well as for India, that someone who is virologically suppressed, as shown here, you can also change this drug to every 2 months of injections. But these drugs are not available in India yet. The Indian companies are already started manufacturing. Hopefully, we'll get this anytime soon. But again, every 2 months. So our patients wanted something a little more longer. Today, many of our oral therapy, they come only every 6 months to the clinic. They're doing extremely well. You ask them to come every 2 months to have a shot, then they may sometimes refuse. For this, to compare this, now we have a new molecule already been developed called lenacapavir, which is a capsid inhibitor. I showed a life cycle where there is a virus, this drug can inhibit these at the level of maturation. So, which has already been studied as a long-acting injectable, which can be given subcutaneously every 6 months, which also been developed as an oral tablet every weekly. Every week, one can take a tablet, or subcutaneously every 6 months. It's already been studied in two different clinical trials, one in ARV naive patients, newly initiating, another one already experienced with multiple mutation. In both the things, it worked extremely very well. And following this, now it has been recommended both for treatment as well as for prevention every 6 months. You would have seen in the newspapers where there is a new injectable for every 6 months for prevention, which I'll browse through at the end if we have time. Again, not just stopping with this, we have a lot of newer drugs available. Again, I'm going into the pathogenesis, but I will not spend more time on this and bore you. There are a lot of new drugs going to come up. Like there's a lot of newer broadly neutralizing antibodies. There are newer reverse transcriptase inhibitors, capsid inhibitors, newer drugs, maturation inhibitors. In fact, my team has been developing this new molecule called HRF10007, which is a make in India molecule, first time in India, developed by Indian companies in partnership with my department, with my molecular virologist, developing new molecule. Very recently presented at the World AIDS Conference, said is working on that. And also there is some newer integrase inhibitor. A lot of new things coming up. Next 2 to 3 years, we'll have at least another 10 or 12 newer molecules for HIV. So with this, people with HIV will never die. We make sure that they can live beyond 100. So that's a way where these fields are coming up. And so, as a clinicians today, don't sit tightly with whatever you learn today and practicing. Keep updating your knowledge. I said about reducing the ERT dosages like tenofovir dropping so that people live longer. Update your knowledge on the new agents because you become part of the guidelines as well as in private practice. And particularly this long-acting injectable is going to be a very critical role. If we are going to succeed, we can do this for all fields of medicine, in hypertension, diabetes, and everything. The same principle can be repurposed. If we are successful in a disease like HIV, we can hit all those using the technology what we are using on a long-acting distribution like in nano preparations can be done on this. I'm going to end soon stating that since you are all internists, so all your life you're seeing all these patients like diabetes, hypertension, and so you may ask, what the hell you're going to talk to us? It's all every day of your life. So today, our major work in our HIV clinic is not taking opportunistic infection. People are doing extremely well with all this antiretroviral therapy, but a lot of our work is on taking care of all this. Today, because of this HIV on a long run, we are not curing them. We are only suppress the virus. Still, it can replicate in a small amount in some of the tissues in lymph node, glial cells, and gut tissues and produce a lot of inflammation and immune activation, causing various non-communicable diseases. These are all age-old diseases everybody develops. We all will develop one day. Why we develop? Because of inflammation. When someone who is aged, they can be inflamed. We're producing all this. What we have seen is HIV causes accelerated inflammation. We have seen this COVID. It's a lot of inflammation. Like CRP went up, IL-6 went up, IP-10 went up. In HIV, we had done studies on this in population much before COVID, stating that causes a lot of inflammation. And because of that, someone who tend to develop a diabetes at 60 years of life, in their HIV, they can develop at 30, 35. Someone who develop a heart attack, who tend to develop because they have a risk to develop an inflammation, if they have HIV, added to that, they can develop an MI at 30, 35. They can develop a stroke. So this is something what we are seeing in our people with HIV. And also over the top, they also have other co-infection like TB. TB also produces a lot of inflammation and variety of opportunistic infection. And microbial translocation and obesity, some of the drugs which I'm going to talk to you soon, can also cause obesity, which all cause a lot of inflammation. And because of this, one of the major problems people with HIV face over a period of time is all these non-communicable diseases where your internists are going to play very critical role in managing this. And also there are several cohort studies have shown higher chance of developing hypertension and dyslipidemia on patients who are on antiretroviral drug on a long run. So hence it's very important to monitor these patients, their lipids, their blood pressures, and all those other assays for non-communicable diseases. We did a very landmark trial. Some of you would have seen, if you're a cardiologist here, you might be knowing. It's called REPRIEVE trial. The trial was initiated by US NIH with support from Harvard and many countries across the globe. Our site in Chennai is also one of the largest sites. Anyone who is HIV positive, they have undetected viral load, were on antiretroviral therapy. They never had any cardiovascular disease. Their lipids are normal, LDL is normal. We recruited in this particular trial by giving statins. We gave statins. The statin what we used was pitavastatin against a placebo. They were continuing antiretroviral therapy. One group, we put them on statin. They have normal lipids. And another group on placebo. We followed them for 7 years globally. So quite a large trial on 7,000 patients. What we found in that is, and it's again a landmark publication, changed completely the face of medicine, is people who are on statins, we all thought statins are to reduce the LDL or treat lipidemia. We never gave statins for normal lipids in the past, only for treatment. So here, what we found in that is people who are on statins as compared to placebo, so where they have a higher reduction of any major adverse cardiovascular events, we call MACE. And also when we looked into the cardiovascular death, which was much lower in people who have got statins. We are so shocked to see this. And also cardiologists never believed this data because they said, these are normal lipids, how are you able to do this? We did a lot of sub-studies on this from the stored specimen. We found that statins has got another one effect on reducing the inflammation. Especially there is a protein called PCOLS protein, which gets upregulated, which causes atheromatous plaque to form, which is called NCP, and caused all this. Statin, causes the expression of this and reduces because there is a less chance of producing these plaques, and thereby it prevented major cardiovascular disease. And following this, US NIH and everything, we published very long, and all the developed world guideline, the US guideline, European guideline, UK guideline recommended anyone who is HIV positive, even if they are on antiretroviral therapy more than 40 years, and even if they don't have a risk of cardiovascular disease, give statins as a prophylaxis in HIV. So we are just now looking into that for WHO and for India because we got a high risk to develop a very cardiovascular disease. And because of various other logistic purpose, little delayed, but on the other hand, we might be using this soon. And also, now US Cardiology Association and other groups are looking at, if it works in HIV, why not you give it to all the general population, because the statins has got such a potent effect. We used pitavastatin, which has just got a lot of inflammatory properties. But on the other hand, atorvastatin, rovastatin also has got the same properties. So you can always interchange along with it. Is something a new guideline we'll see, not only in the field of HIV, even in your general medicine, you may look for anyone who is like 40 years and more, even if they are normal lipids, you may even give statins one day. I do not know, I don't want to debate with your cardiology association here because they have a different way of thinking. We look at the inflammation to prevent these cardiovascular events. And one of the major things what we see in our patients with HIV on a long run, especially on protease inhibitors and as well as with the integrase inhibitors like dolutegravir, is obesity. They put on a lot of weight. My patients say, hey, I used to be perfectly fine with a normal weight, now putting on a lot of weight. What to do? We can't change the drugs. We change the drugs, again, the virus will start multiplying and they develop various opportunistic infection. We did some clinical trials using one of the newer drug called doravirine. I'm not going to the detail. And people who have got a higher weight gain, and we found that there is no difference, no change. So that means we are recommending not to change, but on the other hand, use other lifestyle modification, ask them to exercise, about the drug, which we all do for your patient. Now we are doing for our HIV patient in the day one, other you'll put on weight and cause other cardiovascular events. Again, to combat this, currently I'm also doing a large clinical trial, a global trial, which has been initiated from Chennai side, using dapagliflozin in people with HIV on a large trial. Also, there is another semaglutide, which we all know that we are using. Again, these are some of those newer management we need to do this in people with HIV. We are able to contain HIV. They don't multiply, they live like a normal people. But on the other hand, these NCDs, they find after 20 years, they come with the heart attack again, all those what you have done is all go obsolete. So now we wanted to even protect that, developing newer therapies. You may see more and more on this. I'm not going to release everything. These are all data going on, so I don't have even the information. Maybe next year, if you invite me, I'll be very happy to speak to you all about some of the newer findings. And one of the things I'm sure you might be seeing in your field of medicine is all this MASL and MASH. You all know that the name we have changed, not anymore called NAFLD, which is a non-alcoholic fatty liver disease. There are a lot of people, who are not alcoholic who develop this. It's become a stigmatized disease since it's called metabolic associated steatotic liver disease as well as metabolic associated steatohepatitis. We also see this in HIV. We saw this in hepatitis B and hepatitis C a lot. Now in HIV on a long run, we started seeing people now on this. And also we have even done liver transplant on these people on over a period of time. So now there are a lot of trials currently underway, especially to prevent these complications. Again, wait for this. These are some other things. We infectious disease doctor may not treat these patients. We may refer to you all internists. Hey, my patient on HIV, well suppressed. Now, can you do something to take care of his fatty liver or take care of his obesity? Now, this is something what you have to now take up. That's a huge role, because we have done our bit already, preventing opportunistic infection, treating the virus. But on the other hand, we're going to view to other players how we can move around all this. Now, you can keep on doing this, but still the virus will replicate in small numbers, very tissues. They can cause all the damage. Can you cure them? You cannot cure them. There are reports came from Cochin, from this plain place. There are some Ayurvedic physicians cured and everybody rushed here. In fact, I used to say that The flight fares from many cities were such higher at that time, which I'm talking about in the year 1999, 98, because hardly we had only 3 or 4 flights a week used to be to Cochin. So all fare, because people came to get HIV medicine here from some of your alternate medicine quacks. So finally, we are able to put them using IMA and yes, you have to put them in jail, and because they are cheating people. So a lot of trials going on. How we can cure this? Is one is called, I said, even if you give this virus, it goes to undict level. It can keep multiplying in small ways in lymph nodes and other target tissues we call reservoirs. We are now developing molecules how to get these out of the reservoirs, then kill with this virus. Also enhance using passive immunization. A lot of trials going on. And gene therapy is similar like our Operation Sindoor. Very nice name. I love that. So we have been using this in our trials, how we can introduce molecular scissors into form of gene to these replicating viruses so that they'll replicate falsely. So even it'll replicate. We cannot cure this virus. We have failed. But if we make sure that they replicate falsely in a way it won't attack anyone, it won't transmit, we have done our success. So that means we introduce this. This is something area of science going on. If it is successful, we can take care of many, many diseases, including diabetes, where you can alter their gene, which are predisposed to diabetes, using this. But it can do more harm also. It can do the other way. So this is something, what we have been, targeting on that. The good things out of this will be used for other diseases. And today also we have been using broadly neutralizing antibodies to cure this. But till today, a lot of are still under trial, nothing for in our practice. But on the other hand, 7 people globally were cured of HIV. You would have seen in some newspapers in the past. But these are all by accidentally. What happened is these are all people with HIV who also had leukemia, which you all know that for leukemia, the treatment is not only chemotherapy, we also give stem cell treatment. And at the beginning of the pathogenesis talk, I showed you there are some receptor called CCR5 and CXCR4 plays a critical role in viral acquisition. So what they did is in these particular individuals who got HIV, they gave antiretroviral drug, went to undetectable level. They gave chemotherapy. Then they gave stem cell treatment. They harvested from donors who got CCR5 deletion, and they gave them, by accidentally, they got rid of the virus out because the virus couldn't come back again, get acquired. So again, this is only a principle. We cannot keep giving stem cell therapy to all the 40 million people, which is very expensive because the risk to develop mortality following stem cell therapy is huge. But on the other hand, the principle began, now is developed to develop a cure. So this is something, again, we need to wait for it. So, but on the other hand, again, I want to, I'm going to end my talk. Maybe can I take another 5 more minutes, sir, and talk, saying that today these antiretroviral drugs are not only for treatment, but also for prevention. Someone who is HIV positive, they have undetectable viral load. Studies have shown, ecological data have shown, they will not transmit infection to others. What is called U is equal to U. Undetectable is untransmissible. It will not happen. So I think as clinicians, we are going to tell our patients stating that take the drugs very well. It's not only good for you, but good for your partners. Now you may ask a question, can we prevent this viral infection? We don't have any vaccine. All the vaccines have failed. But whatever we developed and even failed, but other fields have took up this. COVID vaccine, mRNA vaccine, which was initially developed for HIV, didn't work on our patient, on our field. So they took it up. Similarly, a lot of other newer vaccine coming up has been taken up from the sign from HIV. But on the other hand, we have what is called pre-exposure prophylaxis. Before a sexual act, you can swallow this tablet called tenofovir and emtricitabine. We give it for treatment along with dolutegravir, and have a sexual act. You can prevent this based on different clinical trials. What is called pre-exposure prophylaxis. And also there are guidelines from WHO and other different bodies that you can do it. But on the other hand, the studies have shown only if they take it, it will work. Again, how many of them, store all these tablets before a sexual act, to do this? Since it's getting this efficacy, it worked very well, only if you take it. Again, to combat this, now we developed this long-acting injectable for treatment, which has also been tried for prevention in 2 different clinical trials. And it has been found and compared against the oral therapy. And you can see the different numbers where you have more chance of transmission is all oral tablets, where if you see these injectable, you have a less chance of transmission. And following this, US FDA recommended for PrEP, pre-exposure prophylaxis, negative people, you keep taking every 2 months this injection, and you can have an unprotected sex, you will not get an infection. It's already been recommended. People are using this. And again, having every 2 months is shot is very difficult. Now we have gone one step again. Sorry, it's gone away. Did I touch anywhere? So the drug which we developed called lenacapavir, so which for treatment every 6 months, which has been also now been studied for prevention. To do this in a trial called Purpose, what they did is they gave a group of people who had a high risk to develop HIV, like sex workers who had a multi-partner sex, and they studied this against oral therapy. They found that when they give every 6 months, they almost found zero transmission. This is a trial called Purpose trial called Lenacapavir. This is a one we should have seen in the newspaper yesterday and the year before, which I wrote big column on this. So what they found in that is there is almost zero transmission in people who got this every 6 months injection as compared to oral tablet. Here, I'm not saying that oral tablet is not working for prevention. It worked, but on the other people are not taking properly. They're not taking for that. But this injection, you give them every 6 months, they are gone. So they are able to protect this. This drug is so expensive in the US. And now, thanks to our Indian generic manufacturers, this is a news clip from yesterday, which I wrote in the newspaper, that 2 Indian companies, in fact, 5 Indian companies have started developing this. Early 2027, it will be available here in India. It might be around, for a year, it will be like $40. That's around 3,000, 4,000 rupees for 2 injections. So that means if you have 2 shots, you are protected. I may even tell them all healthcare workers have this because we also have a risk. Surgeons have a risk in all our procedures. It will be like a pre-exposure prophylaxis. Probably one day, it can be worked. So not only, we should look at as a population who got a high risk to acquire HIV. Now, everyone have a risk. This is something what may look at that. So again, don't recommend to any healthcare workers at this time. We are looking at what are the other possibilities so that our healthcare workers won't have any fear even on operating on people with HIV because they're already protected. All of you are protected against hepatitis B. Many of you are protected against COVID, against flu and pneumococcal, women against HPV. We're not against HIV because we don't have a vaccine, but on the hand, we have PrEP. Just to conclude, stating that you do all this till HIV bursts. It's a slow chronic disease. You cannot cure them, eradicate them. Several factors contribute. Sterilizing cure has occurred in 7 people, which I said, using this stem cell treatment, but the method is not scalable. But on the other hand, cure is in the promising, using broadly neutralizing and a lot of other things, but we don't have it at this time. But functional cure, suppressing to undetectable level so that they won't transmit infection to others, it is possible, feasible, which you all can do it, you should do it. But on the other hand, preventing resistance and non-communicable disease NCDs should be the future question because we have already contained HIV. I just end this by showing that this is a center which I'm from, which is quite a large hospital called VHS. Some of you have known this. One of the first private hospital opened by Jawaharlal Nehru in the year 1958 when he was a prime minister. We have all specialties, a teaching hospital, where I head the very large infectious disease division, where we take care of a very large number of people with HIV, hepatitis, which is one of the iconic center during the COVID time for taking care of people as well as doing trials. We do a variety of other infectious disease workup. We do variety of research in collaboration with our own ICMR, with WHO and US NIH. We conduct variety of clinical trial, drug development studies in variety of microbes, and with academic universities and publish heavily. Many of them help to change the guidelines. If you happen to come to Chennai, kindly visit us. We'll be happy to give a tour. If you want to get trained, please do come. Again, thank you very much and for the kind invitation and for your time. Happy to take questions.